Dear Chairman, dear colleagues, my name is Luca Hergár, and I would like to present you my progress on my research topic, translational keypoints between radiology, physical examination, and hand surgery. I'm a resident doctor at the Department of Orthopedics at Semmelweis University with a special interest in hand surgery. My vision is effective and safe care for our patients and adequate diagnosis at the first doctor-patient interaction. And my mission is to evaluate the diagnostic accuracy of diagnostic methods in hand surgery. More specifically, I'm working on 3 projects that I would like to present you in detail in the following minutes. My first project is about the right conditions to make a wrist MRI an accurate preoperative diagnostic tool for ligament injuries. Wrist injuries are common but very complex pathologies. Patients with chronic wrist pain, especially if they have a traumatic wrist injury in their anamnesis, are likely to have ligamentous lesions. The gold standard diagnostic procedure for this disease is wrist arthroscopy. That is often preceded by wrist MRI to help clinicians to decide the need for surgical intervention and also to help the preoperative planning. However, in the literature we found that the diagnostic accuracy of MRI is spread on a large scale, but we couldn't really explain this difference. This is why the aim of our study was to determine the diagnostic accuracy of MRI and also to determine the factors affecting the diagnostic accuracy. We included articles examining patients with suspected cartilaginous or ligamentous lesions of the wrist, and we compared the diagnostic accuracy of wrist MRI compared to arthroscopy. Here you can see our results. We found the overall sensitivity to be 76% and the specificity to be 87%. You can see that for the sensitivity and the specificity of low-field MRI is below of 1.5 and 3 Tesla machines. We found that the application of wrist coils and 3D sequences increased mainly the sensitivity of the examination, while fat saturation had a positive effect on the specificity. The anatomic location also played an important role in the diagnostic accuracy. We found the best results at the TFCC lesions, especially if it was distinguished whether this was a central or a peripheral tear. We found that for scapulohumeral ligamentous lesions, the best results were achieved in the case of 3 Tesla MRI imaging. So based on this, we advise clinicians that if they have the suspicion of scapulohumeral ligamentous lesions, they should perform 3 Tesla imaging analysis. The diagnostic accuracy for lunostriquetral ligamentous lesions is still quite low, although the specificity is high. So we would like to warn physicians that in this case, if they have a negative MRI, it doesn't necessarily mean that the LT ligament is intact. In conclusion, we can see that the low-field MRI has clinically low sensitivity and specificity, and for wrist imaging, 1.5 Tesla should be a minimum requirement. The application of 3D gradient and wrist coils increase the sensitivity, and the application of fat saturation and higher field strength increase specificity. Anatomic locations matter in this imaging procedure, so we would like to warn physicians that the best results can be achieved for TFCC ligamentous lesions. For scapulohumeral lesions, we advise the 3 Tesla imaging, and we would like to highlight that the diagnostics of LT ligamentous injuries is still limited by MRI imaging. Although we were limited by the heterogeneity of our studies, we are convinced that our study has many strengths as well, such as the large number of included studies, and also that we examined variable factors, both from technical and anatomical point of view. All in all, we can see that MRI is a reliable tool in the preoperative diagnosis for wrist ligamentous lesions if the technical conditions are adequate. We have completed and submitted our manuscript to the arthroscopy journal, and we are working at the revision at the moment. My second project is about the correlation between 2-point discrimination and electroneurography in carpal tunnel syndrome. In carpal tunnel syndrome, the median nerve is under compression, causing motor and sensory loss of function. To objectify the severity of this disease, the gold standard diagnostic tool is electromyography and electroneurography. During physical examination, we can use two-point discrimination measurement to assess objectively the sensory function of the hand. Well, we define a two-point discrimination as the smallest difference that a person can perceive as two different points during the examination. Evaluating the degree of the severity is important to choose adequate therapy and also for follow-up. The aim of our study was to define whether 2PD has a correlation with electroneurographic results. We included patients to our study with carpal tunnel syndrome who were operated at our clinic, and we compared the 2PD values to the electroneurographic results. Here you can see our main results. We found significant correlation between the distal sensory latency and both the severity category and the values of 2PD measurement. The nerve conduction velocity correlated significantly with the severity category of 2PD, and again, the electroneurographic severity correlated with both the severity category and the values of 2PD measurement. Although these correlations were significant, we found that the correlation coefficient was not very high, so we can't say that these examination methods are equivalent to one another, but we do think that the 2PD measurement can be a useful clinical tool to pre-screen patients with possible severe carpal tunnel syndrome. We were also curious that what is the cutoff point where we can say that patients are likely to have severe carpal tunnel syndrome, and we found this at 9.5 millimeters, where the diagnostic accuracy is 69%. So we advise clinicians based on these results that if the patients have 10 millimeters or higher two-point discrimination value, then they should proceed with the preoperative diagnosis and also with the surgery if necessary, because these people are likely to have severe carpal tunnel syndrome. We have completed and submitted our manuscript to the injury journal, and it is currently at revision at the journal. And my last topic is about investigating the effects of different conditions on two-point discrimination values. As I mentioned earlier, two-point discrimination measurement is a very useful tool in the clinical practice to evaluate the sensory function of the hand. But according to our hypothesis, certain patient characteristics, such as age, gender, pregnancy, cortical function, BMI, or laterality, could have an effect on these 2PD values. And we would like to find out that what is this effect and how important it is, so we could contribute to a better establishment for a personalized 2PD normal value for these patients. We are currently at the full text selection in this project in our meta-analysis, and we plan to continue with our project very soon. At the end of my presentation, I would like to thank you very much for your kind attention with an inspiring quote from Antoine de Saint-Exupéry, "Go without a plan is just a wish." Thank you very much.
Can we go to your first study, actually to the page when you said about your publication? Okay, so this is a strong journal as we see, and then you said that you already actually got the reviews and then you submitted back. Sure. Am I right?
No, we still have the resubmission to do. I submitted it, and then the editor asked for some changes before to send out to the reviewer. So we are currently working on this revision, as they asked for some major statistical changes, and it took some time to complete this.
Okay, so since all the fellows and even we have always this kind of problem that the reviewers could ask different kind of things, and then we may agree or may not. So what was the major problem? So what is the major criticism, and then can you handle this?
The major criticism was about the risk of bias, as we included a lot of studies that were quite heterogeneous, and in some cases also there was a high risk of bias, especially based on patient selection. and they wanted to show this in a statistical point of view. So after a thorough discussion, we decided to that some of the articles maybe have to be left out because of the high risk of bias, and also we created special subgroups for subgroup analysis, so we would have a more I would say like more special results for some topics.
I mean, that happens, so this is not a major fault. I mean, this is actually a process that actually an editorial kind of comments could make the paper much better and much clearer. So I think we should have to approach this in a positive way.
If my friend Dr. Bucci said some anecdotal facts about the past, I would also tell you some. We have Dr. Barta in our institution is an excellent guy in arthroscopic surgery, and he was always complaining in the past that the MRI is not enough sensitive recognizing ECL rupture, which is so thick, and the ligament in the wrist are much smaller. And you mentioned that the sensitivity increase was between 70 to 80, but in this journal was written 10 years before, and now it is between 80, 85. I think these 10 years, it makes a lot of development in this field. You mentioned that the low field MRI is not proper for recognition, and the high field is, but it's only due to the Tesla, the number of the Tesla 1.5 or 3 Tesla, or maybe the software also changed in these 10 years, and these new equipments have much proper software, and maybe it's also a reason that the results are much better.
Thank you, Professor, for your question. If I may come back to this slide, I think that one of the reason is in the field strengths. So that the higher field strengths we can achieve better results. But if we look at these rows, that in the sensitivity there is not a lot of difference between 1.5 and 3 Tesla imaging. So this is why we wanted to assess also other technical aspects, such as the application of wrist coils, which is special for the wrist imaging to increase the sensitivity. And also with the use of 3D sequences, as you mentioned, this is a special sequence that is available from not very long ago. And the advantage of this sequence is exactly what you said, that these ligaments are very small. So earlier, and even in some of the studies that we included, the gap between the slices, what the MRI made, could be up to 3 millimeters. And if the ligament is just in this gap, it's possible that we altogether skip the ligament, and it's not even in the picture. And with the application of these 3D sequences, the gap is basically zero. So the MRI or the software of the MRI creates 3D voxels, and there is no gap in these pictures, and this could contribute greatly to the sensitivity, I would think. And also with the fat saturation, that we decrease the signs coming from the fatty tissue. All these technical advancements, I think they can contribute to a better diagnostic procedure.
Actually, we have had quite a strong hand surgery unit in my center in Székesfehérvár, and I've been able to follow all the improvement in hand surgery, even the MRI. But actually, I have done a note looking through your material. Adequate technical requirements are important, as you pointed out. I fully agree with that concerning the diagnostic specificity of MRI scan in this subject. So just a comment. And the other one, the other question of mine is about the carpal tunnel syndrome. Looking through the literature, have you met a pseudoscan as a diagnostic tool in carpal tunnel syndrome?
No, I haven't.
Actually, it was published from our department, probably not internationally. The sweet glands are innervated, and if you measure use this pseudoscan, you can find immediately exactly where the problem is.
So basically, you're saying that low Tesla MRI you shouldn't do at all for hand because it has no consequence, right?
Yes, in the case of ligamentous injuries, there might be other application. Then it can still have a diagnostic value, but for these small structures, we wouldn't advise.
Yeah. So what do you think about alternative imaging, ultrasound in the future, or maybe even other technologies that might be there in the future? Do you think there might be good alternatives to an MRI on a clinical standpoint?
It's an interesting question because these are very small structures. I don't really have a lot of experience with the ultrasound in these cases, nor in the literature. I think also the MRI has positive quality in these cases, that we can also see the fluid near the joints that kind of lights up the field in the MRI. I'm not sure if in ultrasound it would be this evident to look at. But I think this is an option that we should definitely consider, given the financial aspect of the question as well. And also that it would be a lot easier for patients if we could assess it, for example, during the outpatient care at hand surgery. As I mentioned, this is my vision to have the fastest and the correct diagnosis as soon as possible.
Hi, so it was a wonderful presentation. My question would be concerning the first project. What do you mean by the heterogeneity exactly? Could you share your opinions about that?
Yes, thank you for your question. As I mentioned, we included lots of different studies, and already when we were reading these papers, we found that there's a lot of difference in the scientific method as well, whether they were prospective or retrospective studies, and in the patient selection. Some authors only examined patients with chronic wrist pain. Some of them examined patients where the conservative treatment has already failed. And as I mentioned, that we had this problem with the risk of bias. The main problem was that in some cases, they after they done the MRI, they excluded patients from the follow-up to complete the arthroscopy if the symptoms improved for conservative treatment. So this could mean that we potentially have different results from the reality. And these are all the problems of the heterogeneity and of the studies.
I would like to ask in the clinical part, how can you treat about the severity of the carpal tunnel syndrome, and how can you adjust for the 2-point discrimination?
Thank you. As I mentioned, we would like to assess the severity of carpal tunnel syndrome in the cases of our patients. It's because if they have mild symptoms or a carpal tunnel syndrome that has just started, then we advise them to the conservative treatment, for example, splinting of the wrist, the use of local or oral non-steroid anti-inflammatory drugs. Because according to our experience, it can improve the symptoms and we can delay a bit the surgery. But if we have severe carpal tunnel syndrome, that according to our hypothesis, we can also pre-screen with the 2-point discrimination measurement. We advise to do the surgery as soon as possible if you are certain about the diagnosis, because when there is a sensory loss of function, the recovery is much slower, and also in some cases the sensation doesn't really come back to as it's to the normal state, and this is why we advise the carpal tunnel release as soon as possible.
Okay, you mentioned the diagnostic efficacy. Could you please tell us what does it mean?
Yes, thank you. It means that the correct test results compared to all the tests. So it is a ratio, and we would like to be it as high as possible.